Okay, fine. All right. So this is your seminar number 4 or 5.
Number 4.
Number 4 kan. So number 4, so there's going to be three topics going to be discussed. It's about lymphadenopathy, it's about hypertension, and also child with rash. Normally I do the other way around, meaning that I normally do acute flaccid paralysis, floppy infants, and also seizures. But it looks like Dr. Mossa is going to do those 3 topics. So that's okay. So what we'll do is I'm just going to invite whoever been assigned to these 3 topics to start with their presentation. All right. So it should be Haziq doing the child with lymphadenopathy. Okay.
Yes,
yeah. So it doesn't matter which whoever want to come first. You want to go for ladies first, I don't mind. All right. Up to you guys.
Okay. Me first lah, Doctor.
Okay, that's okay.
Can you see my slide?
Mm-hmm.
Yes.
Yes, eh?
Yep.
Okay. So, Assalamualaikum and very good morning to all of you. So, my name is Nur Haziq. Will present to you about child with lymphadenopathy. So, for introduction, just for recaps that the lymph node are composed of follicle that contain abundance of lymphocyte. So, in children, it is said that the lymphoid mass steadily increase after birth until 8 to 12 years old before undergo progressive atrophy during puberty onwards. So, the function of lymph node is mainly for immune defense and also for transportation of lymph and fat. So regarding lymphadenopathy, it can be defined as the enlargement of one or more lymph node as a result of normal reactive process or a pathologic occurrence, which means either the lymph node can enlarge through proliferation of normal cell in regards to infection or infiltration by the abnormal cell such as cancer cell. So the other sources said that the lymphadenopathy is when there is a presence of one or more enlarged lymph node and the size of that lymph node is depend on what site. So this is some of the causes of lymphadenopathy together with the description on how it's occur. So you can read it by yourself later on. So in general, lymphadenopathy can be classified into generalized and also localized lymphadenopathy. So generalized lymphadenopathy can be defined as enlargement of 2 or more non-continuous regions that often indicates underlying systemic disease, while the localized lymphadenopathy, which can be defined as the enlargement of a single or multiple continuous node, mainly associated with the region involved according to the lymphatic drainage pattern. So this table summarize the list of the lymph node grouped together with its drainage area and the disease that may affect them. Same with this table. So this chart basically categorizes the previous list of disease into localized and generalized one. So you all can read by yourself later on. So for my presentation, I will include only a few diseases for lymphadenopathy. So for the first one is the TB lymphadenitis. So basically, TB lymphadenitis is the reactivation of TB that is seeded hematogenously during primary TB infection. So usually, the cervical and supraclavicular part will be affected, presented with the chronic non-tender infirm mass at the neck areas. So the overlying skin also may be indurated just like in this picture. So however, the systemic symptoms are not common as in the primary one. So the next one is the cat scratch disease that is caused by the infection through the scratch or bite of the infected pet, particularly kitten. So the location of lymphadenopathy depends on the site of inoculation, and the most common location are the axillary, cervical, and supraclavicular. So usually it is started with the development of papule at the site of the trauma, followed by the regional lymphadenitis 1 to 2 weeks later. So the nodes are almost always tender, often have erythema on the overlying skin and occasionally separated, just like in this picture. So in some individual, particularly the immunosuppressive, immunocompromised patient, the organism may disseminate and infect the liver, spleen, eye, and also CNS. So the next one is the Kawasaki disease. So to diagnose someone with Kawasaki disease, we need to fulfill these criteria, which are the patient had 5 or more consecutive days of high-grade fever, plus at least 4 of this condition. So the first one is the conjunctivitis, which is the limber sparing and non-purulent, the presence of the rashes, edema or erythema of the extremity, cervical lymphadenopathy, and also mucosa changes such as strawberry tongue. So for the viral infection, infectious mononucleosis is one of the diagnoses. So this condition is caused by the Epstein-Barr virus that is transmitted through the oral contact with droplets or saliva. So patient will be presented with the prominent cervical lymph node that may associated with the fever and also tonsillar pharyngitis. So on physical examination, the feature that highly associated with this disease is the soft petechiae, as you can see in this picture. Some patients may also have hepatosplenomegaly, maculopapular rash, and also jaundice. So second one is the cytomegalovirus infection that is transmitted through the oral contact, either through saliva or breast milk. So the most common manifestation are the fever, fatigue, pharyngitis, and also adenopathy. Headache, abdominal pain, and diarrhea may also occur in this patient. So last for the viral infection is the HIV, which can be transmitted through placenta. So it is said that a proportion of HIV infected infant may progress rapidly during the first year of life. Some remain asymptomatic before progressing to the clinical disease. So this clinical manifestation is mainly based on the severity of the AIDS itself. So for the mild, they may just presented with lymphadenopathy or parotid gland enlargement alone, moderate recurrent bacterial infection, and the severe one may be opportunity infections such as walk-in pneumonia or candidiasis. So as a precaution, for children with that presented with persistent lymphadenopathy, hepatosplenomegaly, recurrent fever should be tested for HIV test. So next one, we go to the malignancy section. So for malignancy, I will just include 3 of them, which is Hodgkin lymphoma, non-Hodgkin lymphoma, and also leukemia. So for Hodgkin lymphoma, usually presented with painless firm lymphadenopathy at the cervical, supraclavicular, axillary, inguinal, and also mediastinal part. So ada associated symptoms such as B symptom, which is the fatigue, night sweat, and also weight loss, and also extranodal symptoms that can happen such as hepatosplenomegaly, bone pain, and bone marrow failure. So for non-Hodgkin lymphoma, basically the symptom is just the same as non-Hodgkin lymphoma. So it is said that in one study, people outside of the Africa, the B-cell lymphoma mainly originated in the abdomen, specifically at the inguinal or iliac region. So the last, next one is leukemia that may presented with generalized adenopathy for 2/3 of ELL patient and 1/3 of AML patient. So other symptoms include signs of bone marrow failure and also invasion of reticuloendothelial system such as splenomegaly. So the last causes is the drug-induced lymphadenopathy that may develop within weeks of drugs administration. So the symptoms are generalized lymphadenopathy that is associated with maculopapular rash, fever, jaundice, and anemia. So the symptom may subside by itself after discontinuation of the drug. So example of the drug that can cause lymphadenopathy are phenytoin, allopurinol, isoniazid, and atenolol. So that's for the causes. We go to the approach, which is for the history taking in HOPI. We need to ask the site of the lump itself, the onset, characteristic, and any other associated infection and symptom. But we need, the most important is that we need to watch out for any red flag symptom that may indicate malignancy. So the red flag symptom such as supraclavicular lymph node, the lump is hard inconsistency in absence of head and neck infection. The next one, the presence of the B symptoms such as unexplained fever for more than 1 week, night sweats, or weight loss. And for the physical examination and investigation may include hepatosplenomegaly, mediastinal widening on chest X-ray, and also abnormal leg finding that consistent with leukemia and also lymphoma. So other relevant history that may include the past medical history for any immunodeficiency event or any malignancy, drugs for the drug-induced adenopathy, family history for the history of sick contact, feeding history for the consumption of possible infected food such as unpasteurized milk product, and social history for the presence of the domestic pet. So for the physical examination in general, we look for any skin lesions such as ecchymosis, papule, or rashes. Next one is measure the body weight for any weight loss. For the head examination, we look to look for any presence of scalp infection, signs of throat infection, and also mucosal changes. Next, we look for respiratory, we look for any feature of the previous primary TB infection, and for abdomen, look for hepatosplenomegaly. So for the lump and bump examination, just remember the mnemonic, 6 students, 3 teachers go to the campfire, which consists of type, size, shape, surface, skin changes, scar temperature, cleanliness, algeric, biosepha. Okay, so basically, for the investigation, in most patients, only history and physical examination are needed to establish the likely diagnosis. However, if the diagnosis must be further refined, several tests can be performed. So for the workup, it may include the bedside test, blood test, imaging, and also invasive procedure. Depends on the clinical presentation, location of lymphadenopathy, and also underlying risk factor. So this is the list of the investigation that can be done to the patient. So basically for the management, the treatment is said that mainly conservative since most of the lymphadenopathy can regress within just 2 to 3 weeks. But the most important here is to identify the red flag feature of lymphadenopathy first. So to tackle the underlying problems, we need to manage it accordingly. So for the infection, if it is bacteria, we should give antibiotic. For HIV, we should start with heart therapy. And for abscess, we should do surgical incisional and drainage. So if malignancy, we give the patient chemotherapy depending on the underlying illnesses. So basically, that's all for my presentation, Dr.
Okay. So, have you guys, other colleague have any question you want to ask? So just remember that lymphadenopathy is very common in children. Okay. And we normally see them a lot in our pediatric in the pediatric cohort as well. And some of them is just a simple lymphadenopathy that you don't need to do anything else. Especially if the child got lots and lots of lymph nodes that is quite shorty, quite swollen, but does not cause any bother to them, or we call it painless lymphadenopathy. As long as the size is less than 1 centimeter, then you just tell parents that you just monitor it, because if you got a child like less than 5 years old, most of them got a very big lymph nodes anyway, and as your colleague mentioned about, this is the time that the lymph nodes start to getting bigger. Proliferate. It's just it's just a normal pathophysiology. It's not because of pathology that like like malignancy or infection that cause this. So it's quite common for them to have big lymph nodes, especially yang budak-budak yang selalu datang dengan recurrent tonsillitis and yang umur dalam 2 to 3 years, so they come with recurrent tonsillitis. So the reason for that is the tonsil becomes swollen, become bigger every time they got a very simple URTI symptom. The tonsils tend to be infected, so the tonsil become the source of infection, which is very common. So in that particular case, if you got tonsillitis, 5 to 6 times, and it looks like bacterial tonsillitis every time they got tonsillitis, then would refer to the ENT for tonsillectomy. But it's just a common pathophysiology where these children at this age, their lymph nodes tend to get bigger and bigger. The way that you manage them is depend on the pathology, depend on the causes. So if this is infection, you give antibiotics treatment. If you think this is CMV infection, then there's not much you can do about that. EBV, sometimes you don't really do much about EBV itself. If there's any complication from the EBV infections, and obviously if there is Kawasaki or malignancy and so on, then you treat them accordingly. So the most important thing is try to detect and try to find is there any red flag signs for these conditions. Okay, any other question you want to ask? I don't know whether you guys know the epitrochia. There's one slide talking about epitrochia, and I can't remember where was the slide. Yeah, so epitrochia. So previous slide. Epitrochia. I hope that you guys know what is epitrochia. Unless kalau Haziq nak explain where is epitrochia. So I think everyone knows axillary, everyone knows where cervical, everyone knows where inguinal. It's just the epitrochia that we probably don't really use much. So epitrochia is part of your body lah. You need to know where is epitrochia.
If I'm not mistaken, the epitrochia is a group of lymph nodes located at cubital fossa.
Okay, so yeah, so it's around the cubital fossa area. So normally we find around the elbow joints. So those are epitrochia. Okay, any other question about this topics? No? No questions? We can proceed. Yep.
Examination, can we actually appreciate the viral causes, bacterial causes?
You can appreciate. So by doing the physical examinations, and you find there is big lymph nodes. So you won't be able to say this is bacterial or viral. For example, if you have like influenza, and influenza can give you high grade fever, and we normally our rule of thumb, if you got high grade fever, you can be thinking about bacteria. Viral normally tend to be low grade fever, but that's not always the case. We know influenza can give you high grade fever, and influenza also can give you prolonged fever as well. So sometimes I've seen in influenza cases, they got fever for about 10 to 14 days. then you start to worry whether it could be something else. But when you do a blood test looks normal, looks viral picture. This child got your symptom, bit of cough, bit of runny nose, reduced feeding, and then you send a throat swab. It's all negative. You send the nasal pharyngeal aspirates for viruses, then they come back positive for influenza. So we know that influenza can give you high-grade fever, can make you very, very unwell as well, especially in adult, make you very lethargic. You got malaise, you got joint pains, you got muscle ache, you got back pain as well with influenza. But it's not really, even though with that symptom and signs suggestive of bacterial infection, but actually not really bacterial infection. It's actually a viral infection. So yeah, it's a rule of thumb that we normally say to you guys: high-grade fevers, prolonged fever tend to be bacterial, but it's not necessary. It's not all the time. It can be a viral infection as well. But sometimes you can, from the history, you can find knowing that this could be bacteria. But cuma itulah, you need to have a blood test to say whether this is bacteria or not. The most simple or commonest thing that you see is tonsillitis. So sometimes you say tonsillitis. If it's bacterial, you look for a sign of exudates pus on the tonsils. You're also looking at the palatal petechiae. Then if those things present, and then you be thinking about bacterial infection. But if you see, if you have read a few journals and studies about bacterial and also viral tonsillitis, so what they do, I think they swab all. There's a study about swabbing the throat for all tonsillitis patients yang ada exudates. I think they've done like almost 20,000 punya swab, and looking for bacterial on the exudates tonsillitis, exudative tonsillitis. Actually, it's only 50% of them come back bacterial. Ada bacteria on the swab. So despite we putting the criteria to start antibiotics if they got exudates on the tonsils, actually the evidence says kalau the exudates on the tonsil pun is still about 50-50. So not necessarily bacteria, and also palatal petechiae as well, as your colleague present. So normally, if you look at group A streptococcal infection on the tonsil, and so sometimes this group A come with palatal petechiae. Mana kalau tengok kat palate dia ada palatal petechiae kat situ, and then the punya tonsil tend to be exudative. But apparently the evidence does not say so. The evidence only says, this study says it's 50-50. Kalau the exudate pun, it could still be a viral infection, not necessarily a bacterial infection. So I would say that's not really from the history. You kind of knowing that this could be a bacteria, but in reality, that's not always the case. Okay. And the question? Okay, so big lymph nodes, always think about lymphoma. Okay, because lymphoma is a painless lymphadenopathy. So sometimes the child does not really notice there is dia punya lymph node dia bengkak because it's not painful. So the lymph nodes, the lymphoma case I've seen is basically you got a child that looks very well, apart from looking a bit anemic and pale. They just look very well, and because this nodes is getting bigger and bigger slowly. So sometimes what you see today and what you see tomorrow doesn't make any much difference. Okay, the person who can notice this lymph node is the person who's not seen the child for a long time. Faham tak? Maknanya kalau parents tengok dia punya children every day, so they probably don't really notice the small changes. But if you ask, if this child go to balik kampung hometown, so if they're not seen their grandparents for about 2 months, then the grandparent will say, oh, what is that? What is the swelling? because the grandparents probably noticed 2 months ago nothing there, and then now something there. So normally other people will notice them because they've not seen the child for a long time. And then they will notice this lymph node, unless kalau lymph node memang very obvious lah. Tapi kalau just a small lymph nodes yang maybe tersorok sikit kan. For example, one of my case that I've seen a few years ago, there's a 10 years old boy who like well, when I say 10 years ago tu, it's like it's I don't know whether you guys, the boys, know a person called Eric Cantona. Ada siapa kenal Eric Cantona? Tak ada kan? Korang cuma tahu Lionel Messi dengan Cristiano Ronaldo kan? No one knows Eric Cantona. Tak ada? No one knows Eric Cantona. Aklan, do you know Eric Cantona? Haziq, no one know Eric Cantona. Semua orang tahu ni je, tahu Ronaldo ataupun Messi. So Eric Cantona is a football player. Is a Manchester United legend. He's a French. He played for Leeds United before he went to the Manchester United. Okay, fine. I'm not going to talk about Manchester United or Leeds United anyway. What I'm talking about is Eric Cantona, when he put his jersey on, he put the collars up, always up. So that is his style. Okay, so this boy loved Eric Cantona. So he loved Eric Cantona. So every time he went to school, or every time he put on any shirts or any shirts, he always used the collar shirts because he wanted to imitate the style. So what he normally wear, just the t-shirts with the collar, and he always put the collars up. So that's because he want to imitate Eric Cantona. So because he's doing that for a long time, for a couple months and months, and then one day, mak dia saw him went to the toilet, take a bath, coming out from the toilets with his towel, and then noticed this lump in the neck. Okay. And then he told his mom that he got this lump for weeks, probably months, but because it's painless, so he never complained. So looking back at this case, so parents never noticed this because he used to wearing shirts using the Eric Cantona style. So always putting the shirt up, always putting the collars up so that no one see. Well, that is his style. So because of that, no one actually noticed this lump in his neck. So it turned out to be lymphoma for this boy. So sometimes lymphoma can be there for months and months before anyone notice them, because it's painless swelling. Same as painless hematuria kan. So if the child is very independent, going to the toilet by themselves, peeing with the red color, he probably won't say anything because it's painless hematuria. Unless if they worry unless if the child terkejut or shocked with the color of the urine, then the child will complain to parents. But most of the time, if things are not painful, most of the child won't complain. So those are the thing about physiology in pediatrics. Okay, that's one topic. Anything else? Nope. Okay, fine. So let's go to the next next topics.
Okay, Bismillahirrahmanirrahim. Next will be my turn. So I'll be discussing about child with hypertension. So first of all, these are my outlines that I'll be discussing today. So for introduction, some of the research that have been done out there, the overall prevalence of pre-hypertension and hypertension in adolescents were about 11.1% and 11.6% respectively. And whereas in primary school children, it's a bit higher, which is 12.23% and 13.4%. That's why we need to think of if is there any children that came with hypertension or increase in blood pressure. Why? Because about one third of the death in worldwide is due to cardiovascular disease, and we know hypertension is actually one risk in bringing this cardiovascular disease. So in childhood, their blood pressure will predict their adult blood pressure. This is evidence that childhood hypertension can lead to adult hypertension. Now, on the other hand, the presence of hypertension in childhood is actually a early contribution of coronary artery disease. Why? Because there will be early atherosclerosis in children with hypertension. So that's why we need to watch out if there any evidence of raise in blood pressure in children. So what is hypertension in children? It's when their blood pressure it's more than 95th percentile for age, gender, and height on 3 or more different occasions. It's not on the same visit, it's 3 different visits. So about the more than 95th percentile, you can always check in your PIT protocol, the earlier table. There's a definition of blood pressure according to the age, gender, and height. So these are the definition of blood pressure categories according to age. With children less than 13 years old, their normal BP should be less than 90th percentile. So when there is elevated blood pressure before they come to stage 1 hypertension, there is pre-hypertension where their blood pressure will be 90th percentile or more to less than 95th percentile. You can say the 94th percentile lah. Or 120 over 80 millimeter mercury to the less than 95th percentile. When they reach the 95th percentile, that is the stage 1 hypertension. And so in stage 1 hypertension is 95th percentile to less than 95th percentile plus 12. It means plus 11, you can say like that. So, or 130 over 80 until 139 over 89 millimeter mercury. So when they achieve 140 over 90 or 95th percentile plus 20, that is the stage 2 hypertension. This is the one that we need to take attention of. That's for children with 1 to 13 years old. Whichever is lower, we take that they have blood pressure. But in children 13 years old and older, you can take it as like BP in adult, where normal BP is less than 120, less than 80. Where pre-hypertension 120 over less than 80 to 129 over less than 80. So when their systolic blood pressure arrive 80, that is stage 1 hypertension, where from 130 over 80 to 139 over 80. So how we diagnose blood hypertension in children is diagnosis is persistent childhood hypertension, make one, repeat blood pressure on 3 separate visits, like the definition just now, more than 95 percentile for age, sex, and height, or it is more 130 over 80 millimeter mercury or more. Whichever is lower, that's a blood pressure that we jotted down. So for screening, in Malaysia, we started screening at the age of 7 and above. For children with less than 7 years old, without any risk factor, it's not routinely done. We start at 7 years old, and then however, if children less than 7 years old that have risk factor, we need to monitor their blood pressure at each medical encounter. And usually, in routinely, children with more than 7 years old, we check their blood pressure at each medical encounter, or we do it annually if they are obese. However, actually, in newest guideline, latest guideline, they recommended the age of checking blood pressure at 3 years old and above. However, due to our resources in Malaysia, in PITS protocol, we only started blood pressure screening at the age of 7. So we only start blood pressure screening in children less than 7 years old if they have risk factor. Among the risk factors are if they have any history of complication require NICU admission, congenital heart disease, recurrent UTI, hematuria or proteinuria, if they have non-renal disease or urological malformations, family history of congenital renal disease that may think of secondary hypertension, solid organ transplant, treatment with drugs known to raise BP or other systemic illness associated with hypertension. Also, if there is any evidence of raised ICP, because we need to watch out for any uh, cerebral complication. Okay, so if screening, we need to take their blood pressure, how we want to measure their blood pressure. So just the same as adult, we need to use the appropriate cuff size, which is the cuff width cover about more than 40% of their arm distance between the olecranon, acromion to the olecranon. And then the cuff length will cover at least 80% of the circumference of the arm. So if we want to take their blood pressure, we must make sure that the child is seated and arm supported. However, if a child that cannot sit, we can take it in supine position. And then the child must have seated quietly for 3 to 5 minutes rest. It means they have been rested. So we usually use the right arm. Okay. Usually first we use the oscillometric device. However, if we use the device and then their blood pressure is more than 90th percentile, we proceed with auscultatory technique. And then we get 3 readings by the auscultatory technique and we find the average value. So we need to repeat reading in another 2 visits because we need diagnose after 3 or more visits, right? So we repeat and then even after 3 different visits, it's still more, and then we can diagnose them with hypertension. So these are online calculator on how to measure blood pressure. You can find it online. It is from BCM body compact chart page. So you put the birth date because we want to measure their BP according to their age, height, and weight, right? And as well as gender. From there, you can plot the graph chart. So etiology in children, we need to think of 2, whether it's primary or secondary hypertension. But commonly it's secondary hypertension in children less than 6 years old. So in primary hypertension, it usually in children 6 years and more and older with their family history of hypertension, or maybe they are overweight or obese and there's no physical findings suggestive of secondary causes. However, if children less than 6 years old with no family history of hypertension and you look at them, they are thin, not obese, so you need to think of secondary hypertension. So you need to find any physical finding that suggests the secondary causes, the underlying causes that cause the raise in their BP. Or maybe the child came with acute rise of BP where previously their BP is just stable. And if they have any past history of renal disease, drug history, obstructive sleep apnea, or any family history of renal disease. So for primary hypertension, there are few risk factors that we can think of in order to diagnose that this child has primary hypertension. For example, in sex, first of all is obesity. The obesity is high likely causes of primary hypertension in children. Second one is sex. There's studies state that primary hypertension is more, the prevalence is more in boy rather than girl. For ethnicity, I can't find specific ethnic in our country such as Malay, Chinese, or Indian. However, there is studies stated that primary hypertension is more among the African and as well as American compared to Asian. So we kind of at the border at the least prevalence of primary hypertension. Then for breastfeeding is actually a protective factor in primary hypertension, where the study state that if the child have breastfed at least 6 months, it's actually there's evidence that they'll have a lower blood pressure compared to children with breastfed less than 6 months. As well as white coat hypertension, I think most of you know this. It is quite common in children where their blood pressure is high or elevated when they are in medical setting, etc. at the clinic. But their blood pressure at home is just normal. So it's usually due to their nervousness or anxiety by their worrying of going to see the doctors. And also, usually patients with primary hypertension have family history of hypertension in first degree relative. For prenatal and neonatal history factor, there's evidence of low birth weight is actually a risk factor for primary hypertension later on. And as well as mother with preeclampsia have risk of uh, a child with mother of preeclampsia has risk of primary hypertension later on. Okay, that's for primary hypertension. What about the secondary hypertension? There are many causes of secondary hypertension in children, but the most common are the renal disease and renal vascular. Among the causes are parenchymal renal disease and such as glomerulonephritis, pyelonephritis, acute kidney injury, as well as polycystic kidney disease, renal vascular conditions such as renal artery stenosis, thrombosis of renal artery. It can also be caused by endocrine such as glucocorticoid excess or maybe congenital adrenal hyperplasia, thyroid disease, hypercalcemia. Cardiovascular causes such as coarctation of aorta can mess with your blood pressure as well. Central nervous system such as if you even in us adult, right, when we have pain, it can cause raise in our blood pressure. Convulsion, increase intracranial pressure, Guillain-Barré syndrome, and also dysautonomia. Malignancy such as Wilms tumor and pheochromocytoma can also result in raise in blood pressure. And certain drugs can also disturb the child blood pressure such as sympathomimetic drugs, the corticosteroid, the stimulants, and also cocaine. Caffeine also can increase your blood pressure. Others can be obstructive sleep apnea, bronchopulmonary dysplasia, and genetic defects such as Liddle syndrome. So when we meet a child with elevated blood pressure, how we want to approach them? First of all, we need to differentiate whether it is primary or secondary hypertension. If it's primary, we manage accordingly. If it's secondary, we need to identify the underlying factor, identify the risk factor. Uh, and then when we have identified primary or secondary, we find the risk factor, whether it's due to family history or if due to underlying disease. Then we identify the comorbid, whether they have developed any cardiovascular disease risk factor or disease associated with risk of cardiovascular disease. Because as I said just now, 1/3 of death is due to cardiovascular disease. And then if patient with stage 2 hypertension, we identify is there any evidence of an organ injury so that we can initiate treatment to manage the end organ injury to save the patient. So if we want to approach, we need their history, right? So what are the among the questions that we need to know is in history of presented illness, is there any congenital heart defect? Is there any risk factor for cardiovascular disease? History of sleep disturbance, maybe snoring because we want to rule out OSA. And then history of renal disease, urinary tract infection because we want to rule out any other underlying disease. Past medical history, medication and drugs that they take, their antenatal history such as their imaging, their maternal health, because I said mother with preeclampsia can give risk to hypertension, and the drug in pregnancy. Neonatal history, their prematurity, their birth weight, low birth weight can give the risk. Umbilical catheter insertion, because umbilical catheter insertion may cause thrombosis, and this thrombosis may lead to other underlying disease causing the hypertension. Bronchopulmonary dysplasia, medication, congenital heart defects. Nutritional hypertension history, diet and salt intake, because high in salt can also cause hypertension. Family history of hypertension, heart disease, renal disease, and stroke. We want to identify primary or secondary. And social history, is there any the level of physical activity? Because vigorous activity can elevate your blood pressure. And then among the sign and symptom that we may ask as well is there we investigate increase in serum creatinine concentration. Is renal related, elevated serum creatinine, proteinuria, also renal related, hypokalemia, maybe due to hyperaldosteronism. Is there any apneic episode throughout OSA? Is there any flushing, headache, orthostatic hypotension, palpitation to suggest pheochromocytoma? And then arm to leg systolic blood pressure difference. You already know about the coarctation of aorta, right? Maybe there'll be delayed or absent of femoral pulses. and also there may some murmur. And then in Cushing syndrome, you can look out for buffalo hump, central obesity, moon phases, right? As well in thyroid disorder, maybe you can bradycardia in hypothyroid, tachycardia in hypothyroid. Is there any cold or heat intolerance, constipation or diarrhea according to hyper or hypothyroidism, as well as any irregular, heavy or absent menstrual cycle? So this is how actually you want to differentiate primary and secondary, as well as if you know it's secondary, what are the underlying causes. So then when we have find the state of hypertension in these children, we need to identify is there any red flag symptom and signs, because if there is existence of red flag, it may indicate that this patient have target organ damage. For example, if maybe they can have hypertensive encephalopathy if they came with nausea or vomiting, headache, visual disturbance, behavioral changes, altered mental status, as well drowsiness or seizure. Watch out also for any cardiac failure such as chest pain, breathlessness, edema, gallop rhythm, cardiomegaly, as well pulmonary edema. It's more the same in adult as well. And also hypertensive vascular changes increase in intracranial pressure, where in fundoscopy we may find retinal hemorrhage, cotton wool lesion, as well as papular edema. You know that papular edema is indication of increase in ICP. So watch out for this so that we can treat accordingly. So this example of physical examination finding according to your underlying, you can find tachycardia or any decrease in blood pressure, difference in extremity blood pressure to indicate coarctation of aorta. In eyes, look at the retinal change. Ear, nose, and throat, look at adenotonsillar hypertrophy. Height and weight, is there any gross retardation or not? Head and neck, moon phases can suggest Cushing syndrome. In skin, maybe pallor or flushing can indicative of pheochromocytoma. For chest, is there any murmur? For abdomen, is there any mass? Is there any bruit? Or maybe palpable kidney in polycystic kidney disease? Genitalia, is there any ambiguous or virilization in adrenal hyperplasia, as well as their extremities? Is there any swelling to indicate maybe the systemic lupus erythematosus, and also muscle weakness in hyperaldosteronism? So how we do investigation? Routine investigation that will be done in children usually urine dystich for proteinuria and hematuria, because mostly due to renal disease for secondary hypertension. Urine culture for infection, maybe due to UTI. Low blood count, is there any infection as well? Blood urea, serum creatinine, and electrolyte. We need to know the function of the renal, is there affected or not? Thyroid stimulating hormone, because hyper or hypothyroid may alter their blood pressure. Abdominal, renal, and urinary tract ultrasound to find is there any mass effect or not. And then we investigate their comorbids. Maybe they have hyperlipidemia, so first fasting lipid profiles, and then fasting blood sugar with or without HbA1c. Is there any evidence of diabetes? So, and then we also if we suspect any target organ damage, we may do echocardiography, because about 40% of children with hypertensive, they may have left ventricular hypertrophy. So we need to look at the ejection fraction of the left ventricle. And then we up until here, if there are any other specific things that we want to know, we can take the other specific investigations accordingly lah. Okay, so we have we have the history physical examination. Now how we want to manage. So our target, if we want to manage children with hypertension, there's two. If these children with hypertension doesn't have any renal disease, chronic kidney disease associated with it, our target is to reduce their blood pressure, diastolic and systolic less than 90 percentile and less than 130/80 in adolescent less than 13 years old. However, if these children have associated with chronic kidney disease, our target is to reduce their BP less than 50th percentile. So how we manage them? There are two ways, pharmacologically or non-pharmacologically. So usually in primary hypertension, we use non-pharmacologically because their risk factor is actually obesity. So exercise, weight loss, and then low salt or no added salt diet, and cessation of smoking. Because nowadays children who smoke is not rare. It happens. And so if we fail non-pharmacologically, then we think of pharmacological. So indication of pharmacological is actually if their hypertension fail lifestyle modification, or they have symptomatic hypertension, or they have stage 2 hypertension without any clear modifiable factor, such as she's not obese, but she have stage 2 hypertension. So we need to start pharmacological. And then is there any stage of hypertension associated with chronic kidney disease or diabetes mellitus? Because our aim is a bit higher, less than 50th percentile, so we need the help of pharmacological. And also hypertensive and organ damage, most often left ventricular hypertrophy, need pharmacological treatment. Then we already know hypertension also have hypertensive crisis, right? So it consists of hypertensive emergency, hypertensive urgency, and hypertensive encephalopathy. That's why we also need to watch out for the red flag. Hypertensive emergency is defined as an acute severe symptomatic elevation in blood pressure with evidence of potentially life-threatening symptoms or target organ damage. And usually in hypertensive emergency, their blood pressure will elevated far more than the stage 2 hypertension. And then hypertensive urgency is acute severe elevation without the target organ damage. Whereas in hypertensive encephalopathy is characterized by severe blood pressure elevation with cerebral edema and neurological symptoms. In hypertensive encephalopathy, it can be produced without extreme BP elevation when hypertension appears sudden onset because our brain cannot compensate the sudden increase of the blood pressure. So if this happens, how we manage them? So management of principal hypertension emergency, first admit them to at least in high dependence wings or ICU. And then we have to have vascular access for any pharmacological treatment. And then we need to monitor their vital sign, their neurological status, their cardiac, their BP, urine output, and then manage any serious complication that existed at that time. Lower their BP promptly but gradually, not rapidly, because rapid lower blood pressure cause intracranial bleeding. And then our initial goal is to reduce the mean arterial pressure by approximately 25% over the first 24 hours. It's not totally back until normal at that point of time. So in emergency, hypertensive emergency, it usually always use IV drugs and continuous maintenance. But in hypertensive emergency, if the patient can tolerate oral, we can use oral drugs. So these are among the drugs that we use in kids with hypertension. We have ACE inhibitor, angiotensin receptor blockers, thiazide diuretics, calcium channel blocker, beta blocker. And as well as in hypertensive drug for hypertensive emergency, we usually use labetalol, nicardipine, hydralazine, esmolol, furosemide, nifedipine, captopril, and minoxidil. So about the doses, you can read after one in their PICS protocol. All these are in PICS protocol. Okay. So how we want to initiate drug pharmacological treatment in children? First, we begin with recommended dose of the desired drug monotherapy. You can choose any either one from the table just now. So we start with the recommended dose and once daily dosing. However, if after we start the monotherapy, the BP is not well controlled yet, we can increase the dose until maximum or until the BP target is reached. But if it fails as well, we can add the second drug and titrate it as with the initial drug. Usually the second drug is thiazide drugs. But if after second also not achieved, we can add the third drugs of different class. Or at this point in time, we can consult pediatrician expert in childhood and adolescent hypertension. So basically that's all from me. Thanks.
Okay, thank you very much. This is a very, very simple, common, and also what I call it thing again? Simple, common, and also because everyone's talking about it. Childhood obesities and cardiovascular condition problems and so on. If you want to do a study about this in medical center, so you can do a study about this in medical center as well. But obviously, dia kena buat research proposal and so on. But it can be kind of like medical student projects if you want to do it. Macam prevalence of hypertension in children's in a single center study, and so you can do this as well. So what you can do is everyone admitted to the ward, or everyone coming to the pediatric clinics, they all been BP been measured, and then you can do like if you got 100 patients, so how many of them yang ada hypertension, but obviously you exclude the one with nephrotic syndrome or kidney problem or cardiovascular condition, and so you just measure a child with no risk factor first. And so when I say risk factor, means that it's not cardiovascular conditions, not known to have cardiovascular condition, not known to have kidney conditions, and then you can do this. You don't need to do three occasion, just do one occasion, and then probably repeat it multiple times, between 15 minutes interval, just to see the reading, and then you can do a data analysis to see how many percentage of children yang datang pediatric clinics in UIA in medical center that has hypertension ataupun newly diagnosed hypertension. Okay, so hypertension is a very common topics. It's a good topic for discussions. You kind of like need to know in terms of pathogenesis and also causes of hypertension, especially kalau ada raised ICP. How come raised ICP lead to hypertension? You need to know in terms of PSGN or glomerular nephritis that lead to hypertension as well. So you kind of need to know different pathology or pathogenesis of hypertension depending on the individual conditions. One third of, as Nadia says, one third of mortality is due to the cardiovascular disease worldwide. And looking at our Southeast Asian trend at the moment, there are more and more adults and also more and more children's now obese as well. So the trend is worrying. Okay. If you look at the recent data about obesity, I think Pahang is number 3 childhood obesity, not childhood obesity, obese population. So the first one is obviously the KL, the second one is Selangor, and then Pahang is the third on the rank for population with obesity. So it's a trend, and then obviously because of the dietary, because of the activities, and it's all because of the screen time. And so not lot more children nowadays, they have phone, they have gadgets, they have iPad, they play PlayStation ke ataupun Wii Sport and so on, but this is all the routine that lead to their unhealthy lifestyle. If you look nowadays, I don't know, my time before this, I don't really have kafa, I don't really have sekolah agama. So normally I go to school in the morning. In the evening time, I become monkeys, where you basically cycling your bike, you climbing up the trees, you go to the longkang and so on. I don't know, your time was the same time as mine. But when I see my kids nowadays, they go to school in the morning, and then in the afternoon they go to kafa schools. So they don't really have much physical activities apart from time masa kat sekolah. Adalah orang kata PE and physical education, and probably they play in between classes ke ataupun masa rehat, masa recess they play as well. So that's fine, but I don't really see much in terms of much time they can do themselves in terms of doing physical exercise apart from during the weekend or during the cuti sekolah and so on. And obviously with the MCOs for the past 3-4 months, people don't go out, people just stay at home. Most of the child basically sleep very late at night and then wake up during tengah hari time. I'm sure you guys also doing the same thing as well for the past 3 to 4 months. So you can measure your own weight and see how much you gain. Okay, so that's my ranting for today. Any question about this topic?
Doktor, I would like to ask, in practice, kita kena ada dua-dua reading ke systolic atau diastolic to diagnose child with hypertension, the either one je?
So normally I would say if you got a normal reading, then you just take the normal reading. If you got high reading, so you probably need to we normally repeat twice. Let them settle down first, let them rest, let them calm down, and you repeat it again second time, you repeat it again third time. So what you do is you take the lowest measurement. Okay. It's not like you doing weight kan ataupun you doing measurement of the head circumference. Head circumference you need to do 3 times, and then you need to take the average for the BP. If it's high, then you need to repeat, make them calm down, make them relax, and then you repeat again on the second and third occasion. Okay. If all 3 readings are still high, then you need to do what we call manual reading. So because first normally nowadays kita pakai automated machine kan. Kalau tiga-tiga automated reading tu high, then you need to do manual reading, mana pakai BP cuff, and also listen with your stethoscope to get the reading. So if that is still high as well, then the next step you do is you do call it Doppler BP. Means that you got the Doppler punya apa yang macam atas macam masa pregnancy kan kita pakai satu machine untuk detect heart rate of baby kan. So you can use that as a Doppler kind of BP measurement. So you still do the manual cuffing, and then you just use the Doppler to detect the first sounds, and also the subsequent sound to know the systolic and also diastolic punya reading. So those are the way that normally we dia punya step of measuring the BP. But nowadays kita pakai automated. So kalau the first automated reading is normal, then that's fine. Kalau automatic, and if first reading abnormal or high, then you ask them to relax first, to chill out, to calm down, and then you do the second and third reading. If the second and third reading still quite high, then you do the manual with your BP cuff and also your stethoscope. If it's still high, then you do the Doppler BP measurement. So those are the way normally we do it untuk high BP.
Tapi doktor, do we need to look at both systolic and diastolic or either one je? Maksudnya kalau macam
it's mainly looking at the systolic. It's mainly looking at, okay. But in practice we look at the systolic, especially for the hypertension. Cuma kadang-kadang tu if you see a diastolic quite high, then you probably just need to think about probably monitor first. You don't you still need to take both reading systolic and diastolic. Tapi kalau satu je, maknanya kalau diastolic je a bit high, then at the time you probably just observe for the time being. Because high diastolic probably not really significant if the systolic is normal. Cuma yang lebih penting adalah if the systolic is always high, then you expect the diastolic will be high as well. So those are the things. Cuma kadang-kadang there is a leeway on the diastolic ini. So sometimes you allow about +5, -5, and sorry +5 and mainly. So normally you expect the diastolic should be if high, normally the systolic also high as well. And rarely in children you see the diastolic dia high tapi systolic dia normal. So rarely in children.
Okay, thank you doktor.
Okay.
Right. I have one question. Regarding the hypertensive emergency management, hypertensive crisis management. So, what is the most common drugs that we use for manage? Like in adult, we use IV labetalol unless contraindicated. But in children, is
so the hypertensive encephalopathy kan? Is it?
Hypertensive crisis.
Hypertensive crisis.
Either hypertensive emergency or urgency.
Okay. So I think our PITS protocol got the apa tu ada dia punya management dia, and then we also use IV labetalol as well for hypertensive crisis.
Meaning that the most common we use is IV labetalol, doctor.
Yes, normally we use IV labetalol. Need to look into can't remember. I don't know whether Nadia seen the PITS protocol about hypertensive crisis. Because normally we use labetalol for hypertensive crisis anyway.
Okay, thank you, doctor.
So, do you see that protocol in the PITS protocol?
The one I said here is the one for PITS protocol. However, there's not stated which one first or which one second.
Oh, yeah, I can't remember. Because I thought last time I did see the PITS protocol about hypertension, hypertensive crisis that you use IV labetalol. Unless if they remove that for this new edition.
This one, this is the table for hypertensive emergency drug, and the first one is IV labetalol.
Yeah, that's one. Yep. Okay, so it doesn't really mention which one to use, and normally you basically assess them first. So you assess is this child basically hypertensive due to fluid overload or ataupun benda lain. So normally we always start with the IV labetalol. The reason that we start with IV labetalol is because the half life there is not a long half life. So that's why you use IV labetalol. Some center use hydralazine as a first line, and then labetalol as a second line. But it doesn't really matter which one you use. You just need to measure. You just need to make sure which medication your center is doing, or as a first line or second line. I think medical center has labetalol. Medical center has hydralazine as well. Osmolar, I'm not so sure. And then we tend to use furosemide, nifedipine, captopril. This is kind of like maintenance rather than as a hypertensive crisis kind of management. So we tend to use labetalol first as our first line for hypertensive crisis. So it's mainly hypertensive emergency. The crisis, you don't need to go for IV medication straight away. So sometimes you can wait with just nifedipine first, and then see what's the effects from that. But obviously in the emergencies, you go for IV labetalol, or sometimes you can use IV hydralazine as well. So when I work in Leeds General Hospital a few years ago, we tend to use IV hydralazine as a first line, and then second line IV labetalol. But in pregnancy, kalau macam preeclampsia, I think they used to use a labetalol as a first line. Because I do remember that there's a topic about pediatric crisis, hypertensive crisis, and also hypertensive emergencies in the PITS protocol. Tapi macam dia dah, I think they remove this from the current new edition.
These are the content in PITS protocol.
I know.
Only this one. There's no more elaboration.
So it's probably I think the fourth edition ini dia dah remove yang previous punya apa, ada parts for hypertensive crisis dengan hypertensive emergency, and then they put down the management, recommended management for them. Tapi tak apalah. As long as if your center's got labetalol, and then you can start with labetalol for hypertensive emergency. Or if you don't have labetalol, then you can go for hydralazines. Because it's all the hospital depend pada costing. So kalau dia mahal, then they go for a cheaper option.
Thank you.
Okay.
Doctor.
All right.
Can I ask a question?
Yep.
I would like to ask for usually in AKPKD you can have like you can present with hypertension, but in autosomal recessive polycystic kidney disease, do they commonly present with hypertension in the PITS cases?
Okay.
So the question is like usually do they present with hypertension in
polycystic kidney?
Autosomal recessive. Because autosomal recessive is common in prenatal in
normally in children, kalau macam yang PKD ni, orang kata apa, if they presented at birth, they normally been detected masa antenatal scan, kan? And polycystic kidney disease yang datang masa umur dah besar sikit, they tend to be incidental findings. Maknanya if you do the BP and the BP they persistently high, tapi the child looks very well in themselves. And because it's a persistent hypertension with no causes, then normally you do the ultrasound scan, and then because of that, then you will get the diagnosis of polycystic kidney disease lah. So it tend to be incidental findings for the hypertension. So when you do the BP, it's persistently high, and then you do the further investigation, and then you then dapat diagnosis of PKD. So normally, as I said before, hypertensive in children is sometimes it's just a silent hypertension. So they don't really have they don't really have a specific sign for them. And the PKD, polycystic kidney disease, they don't really come with recurring UTI. However, they probably presented with macam poor weight gain, failing to thrive. So those are the symptoms that come with polycystic kidney disease, because it's kind of like chronic condition. And then sometimes if they come too late, they already developed chronic kidney disease, and so the renal provider sometimes can be deranged already at that time. But they normally come with other symptom or other presentation, as I mentioned, like the failing to thrive or poor weight gain, or sometimes they can present with prolonged headache sometimes. So those are the things that come with hypertension with PKD.
Thank you, Doctor.
Doctor, can I ask questions regarding secondary hypertension? May I ask if once we correct the causes of those secondary hypertension, can we wean off the patients from antihypertensive medications, Doctor?
Macam mana sekali?
In cases of secondary hypertension, when we already treat the underlying causes, if it is treatable, can we like wean off the patients from the antihypertensive medication, or is it lifelong, Doctor?
So it's depend on the condition lah. Kalau dia datang because of the, for example, like post-strep glomerulitis, and so they datang with infection, and then they got PSGN, and during the acute condition, so the BP will be high. So in that particular case, you will need to start on nifedipine or ACE inhibitor to control the BP. So at that particular time, you probably just need to you just want to make sure that the BP is always normal, so that it does not cause damage to your basement membrane, to your glomeruli, because if you damage them, then most likely that the child will develop hypertension all their life. So by doing that, you're hoping that you reduce the damage to the glomeruli. So hopefully, once the PSGN kind of like subsided and resolved within 18 months or 2 years, so hopefully the child will not need anti-hepatitis medication. Okay, so but it does not mean that kalau macam BP dia tinggi, macam our experience with PSGN, they normally come with high BP, must acute setting. So after a few weeks, the BP will be normalized again. So not all conditions will require prolonged anti-hypertensive medication. Tapi kalau dia macam ada cardiovascular conditions, then most likely they will require antihypertensive for quite a long time lah. And kalau dia ada guna artery stenosis, then they need to be on the medication until we probably need to correct the stenosis, and so those are the things. So it depends on the causes. Kalau causes to treatable, then most likely the child probably won't need medication for lifelong. For example, kalau dia ada maybe Williams tumor, so Williams tumor dia kena buat resection, get rid of the tumors, probably need to maintain on the antihypertensive for a while, and hopefully at some point, maybe they have chemotherapy and so on, and the hypertension is resolved, and then they probably don't need antihypertensive medication anymore. So it's all dependent on the every individual conditions. Okay, not all of them require lifelong. Some of them might require depending on their pathogenesis. Kalau macam orang yang obese kan, so they might need they might be hypertensive, so they might need antihypertension until they maybe kena buat kurangkan berat badan, dia exercise properly, diet control and so on, and hopefully at some point the BP will be normalized by itself, and they don't really need antihypertensive medication anymore.
Thank you, Doctor.
Okay. All right, last topic. Siapa buat ni? Okay.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So I'll be presenting. I'm the last presenter for today's session. Do you see my slide in full view or not?
Not yet.
Okay. So I hope you can bear with me since I'm the last presenter for today. So I'll be presenting regarding the child with rash. So this is among the common presentation in children. So first, to avoid you from being sleepy, just sit back and take a deep breathing first. Okay. So I'll present the child with rash. So this is my outline for today. So I will explain to you regarding the types of rash that we got and the causes of the rash according to each type, and approach the child with rashes, including history, physical examination, investigation, and also treatment. So first one, we go to the types of rash. We need to recognize the rash first. So we can classify rash according to its pathology or its characteristic. So according to the up-to-date, the pathology is classified either it is a primary or secondary lesion. So for the characteristics, it's either we divided into the character of the rash itself, either flat, raised, fluid, or hemorrhagic. Okay. So for the primary and secondary lesion, the primary lesion, it represents the initial pathologic changes of the rash itself, like the initial presentation of the rash, which includes, this is the list of the rash that includes in the primary lesion. So for the secondary lesion, so it represents the involvement changes of the rash, which is the result from the scratching, infection, and also healing of the rash itself. So this is among the list of the types of rashes that we got in secondary lesion. So for the rashes, I think it's easier for us to classify according to its characteristic, which is easy for us to remember also. So it's either flat, raised, pulpy, or hemorrhagic rash. So for the flat rash, it include macule and also patches. The difference between them is the size of them. So I will explain for the details in each type of the rash. So for the rash, include papu and subplug. For the pulpy, there is a vesicle, bully, and also pustin. For the hemorrhagic, ecchymosis, pupil, and also PTK. So let's go to the flat rash, which is the macules and also patches. So the macules and patches, it is a flat rash. So the difference is macules is less than 1 cm and for the patches is more than 1 cm. So we can
Tak dengar pula. We lost you, Nadia.
Nano.
Nano tak dengar suara. Dengar dah ke?
okay. Sorry. So
Start dari yang macules tadi tak dengar.
Okay. So for the we got papules and also plaques. So for the papules, it is a raised lesion which is palpable. So it is less than 1 centimeter. So the picture indicates the patient with urticaria. So we can see the papules. And so this the picture for the next picture. This is can you see my cursor? Okay. So for the plaques, so it is more than 1 cm in diameter, and this is a picture with patient with psoriasis. So we go to the fluid-free rash, which consists of vesicles, bullae, and also pustules. So for the vesicle or bullae, it contains a clear serous or hemorrhagic fluid, which is vesicle less than 1 cm, of bullae is more than 1 cm. So it basically is a larger vesicle. So this picture is a patient with herpes simplex infection, which is a vesicle. And this picture is patient with toxic epidermolysis, which having a bullae more than 1 cm. And also this is a pustule, which is contain purulent materials. This picture indicates patient with inflammatory acne. Okay. So we go to the hemorrhagic rash, which consists of ecchymosis, pupil, and PTK. So PTK is basically a pinpoint lesion, which is less than 2 mm. And pupilla is between, the sizing is between the ecchymosis and the PTK. And then for the ecchymosis, larger pupillate lesion, which is more than 1 cm. Okay. So let's go to the causes of the rashes. So I divide into like the causes according to the types of rashes. So we go to the macule and also papules. So if a macule rashes, we can divide either it is erythematous, hyperpigmented, or hypopigmented. So this is basically the causes that can cause this type of macule rashes. So for the papule, it can be isolated or in the eruption state. So this is among the common example that causing that papule lesion. So I mean for the more papula lesion is the most common causes of the rash that we can see. So I divide it into bacterial causes, viral causes, or ideal causes. So for the bacterial causes and also this viral causes, I'll go to them one by one. Okay, but not that too detail. Okay. So for the first one, bacterial causes that causes by the scarlet fever that causes by a GAPS infection. So group A, beta hemolytic streptococci. So the rash is described as a sandpaper rash. So it's under maculopapular but described as a sandpaper rash. And then usually scarlet fever is accompanied by the strawberry thumb, and also we can see injected tonsil as a result from the GAPS infection that patient may complain of the sore throat. Okay. So the rash distributed from the head until to the blister, which is to the toe. Okay. The distribution pattern of the rash. Okay. And then that's next is also a bacterial causes, which is caused also by the GAPS infection. So the types of rash that we can see in this patient is we call as erythema marginatum. Since we can see the rash is at the margin is red, while the center is like a normal skin. So actually erythema marginatum only less than 5% of the patient that may present with the rash first. However, about 80% of the patient manifest as negative polyarthritis at the first symptom. So the diagnosis of rheumatic fever we made through the Jones criteria that must be fulfilled. Okay. And then for the next the viral causes. So the first one is Varicella infantum, which is caused by the HHV6. So patient may presented with sudden high-grade fever for 3 days duration, and then the rash will develop as the fever subsides. So usually transient rash, like about 24 hours, will disappear. Like it is erythematous maculopapular rash, and often associated with lymphadenopathy and also Nagayama spot. So Nagayama spot, it is a red spot that found on the soft palate and also uvula. Okay. Next is erythema infectiosum. So it is caused by the human parvovirus B19, also known as the fifth disease. So there are 3 stages of rash in this disease. So the first one, patient may present with erythematous facial flush, which we call it as a slap cheek appearance, as you can see in the picture. So the next stage, a patient will be presented as diffuse erythematous macules that spread on the trunk and also extremities. And then the typical rash is the rash reappears when exposed to sunlight, heat, exercise, or stress. However, this disease is benign and also self-limiting. And then the next one is measles, also known as rubiola. So it is a macular rash that spread in subparulocaudal pattern, which is from the head until to the toe. So the pathognomony of this disease is we can see the Koplik spot. So Koplik spot, basically, it is a white spot with erythematous base. Okay. As you can see that the cursor. And then there are 4 periods in this disease, which is consists of incubation, prodrome, exanthum, and also recovery period. And then for the rubella, so it is caused by the rubivirus. So the rash is described as a small, irregular, and pink macule rash. So it's also associated with Forshammer spot. Forshammer spot is a petechial spot that we can find on the soft palate. However, only 20% of the patient manifest this Forshammer spot. So it can be also associated with lymphadenopathy and also self-limiting. So next is the other causes of the maculopapular. This is Kawasaki disease. So eventually it is a systemic vasculitis, and the rash is a maculopapular rash and polymorphous in nature. So to diagnose the Kawasaki disease, the patient must have fever at least 5 days, and also 4 out of 5 of screen must be fulfilled, which is conjunctivitis, rash, edema, adenopathy, and also mucosal bleeding, mucosal involvement. Okay. The next one is atopic dermatitis. So this is among the common disease that we can see in the childhood. So it is basically a chronic inflammatory itchy skin, and often patient may complain that it has a triggering factors that lead to the flight of the symptom. So the cardinal signs of the disease is patient may have a dry skin and also severe pruritus. And then when patient presented with flare symptom, which is acute eczema, it is characterized by intensely pruritic erythematous papules, and then it may evolve to vesicle, exudation, and also crusting. So this is the common site of the atopic dermatitis in younger children, which are the cheeks, neck, chest, elbow, and also knee. So this is a diagnostic criteria for atopic dermatitis according to the PICS protocol. So it is by Hanifi and Rajka criteria, consists of major features and some minor features. To diagnose, we must have 3 of the major features. So next we go to vesicle bullet also pusting, which is the fruit feel rash. I also divide into bacterial causes, viral causes, and also other causes. So the first one is impetigo, which is caused by the bacterial infection, and usually caused by the staph or the Coccus aureus and or Streptococcus infection, can be both. So the rash eventually begins as erythematous macule and proceeds to vesicular, pustular, or bullous, and then it ruptures to form honey colored custard lesion. So basically, why it is under vesicular or it is under fruit-filled rash, because patient may present to us with like it's already a fruit-filled rash compared to erythematous macule. So this disease is highly contagious. However, it is localized. Okay, so next is viral causes, which is chickenpox, the most common one also, caused by the varicella zoster virus. So these rashes, they spread from the scalp hair to the trunk and also extremities. So patient may present with intense pruritic rash. So this is the involvement of rash. First, it presents as erythematous macules, then proceed to papula, vesicles, and also crust.
So the next one is hand, foot, mouth disease. So it is caused by the Coxsackie virus A type 16. So the first stage of this illness is the most contagious period. So it consists of 4 stages. However, patient may present at the stage 1, which is patient complaint of oral ulcer, which is we call as herpangina, and then with vesicular rash at the hand, foot, and also mouth. That's why it's called as hand, foot, mouth disease. So the next one is scabies. So it is a highly contagious disease. The patient also presented with pruritic rash. So the common site in adult is interdigital space, axilla, groin area. However, in very young children, patient represented the site of the rash is at the head, neck, face, palms, and also sole. So it can spread through a direct contact. So the next for idiopathic is Stevens-Johnson syndrome. So eventually, this is an emergency condition in this cutaneous lesion. So it is a severe mucocutaneous reactions that commonly triggered by medications, can also triggered by viral infection that characterized by extensive necrosis and attachment of the epidermis. So usually it involves 2 or more distinct sites, which is include ocular, oral, and also genital. So eventually the rash begins as ill-defined colisting erythematous macules with purpurate center. Although many cases like we presented to us with diffuse erythema. So the main prominent symptom of Stevens-Johnson syndrome is patient may complain that the skin is tender and pain, and the pain is out of proportion to the cutaneous findings. So the last classification of rash is hemorrhagic rash. So it includes bacterial, viral, and also other causes. So I'll be explaining about the HSP and ITP. And then for the HSP, which is hydroxylamine purpura, so the hallmark of the HSP is we can see the palpable purpura. So this rash is commonly seen at the dependent area, which is at the extensor part of the lower limb, buttocks, and also the below of the waist. So often HSP associated with the common organ which is at the joint, which is patient presenting arthritis. So if patient complain of abdominal pain, we need to check for complication of HSP, which is into susception. So there will also can be a renal involvement, patient complain of hematuria. So diagnosis of HSP is made based on American College Rheumatology classification. So it must have 2 out of 4, which the 4 consists of like palpable purpura, bowel angina, and diagnosis is made by the biopsy. And also the 4th one is the age must be less than 20 years old. So must be 2 out of 4. Okay. So next one is ITP. So ITP is common definition for HSP. So it usually preceded by viral infection, which is the rash will appear 1 to 4 weeks after the viral infection. So it presented as a petechiae and purpurate rash with or without superficial bleeding. So patient may complain also a bleeding tendency such as epistaxis, gum bleed. Okay. So let's approach the chart with rashes. So first we go to the history. So for the history, we need to know the age and sex of the patient, since age and different age and also sex can give different clues to diagnose the common disease for that category. So the rash, we need to know about the characteristic of the rash. Like we need to know the types of the rash just now, and also we need to know the pattern of distribution, how and the site of the rash located, and the progression pattern of the rash, also timing onset, also changes in morphology, like the involvement of the rash itself. Okay. So associated symptoms, we need to the most common is fever. So the most common associated with fever is asymptomatic disease, which is viral causes. So we need to know the important relationship between the fever and also the rash. Okay. So we need also to ask if the condition of the child ill or not. So if very ill, we must have suspicious of patient in septic, like in meningococcus septicemia, patient may appear very ill, septic looking, and also in measles also can be because of the high fever. So and then for the rash, is it associated with itchiness or pain? Which is when the itching, the common one is hemorrhoids, like I mentioned just now. It could be also scabies and other causes of itchy rash. So if we need to ask the patient if there is any triggering factors for the rash. So it is a common in atopic dermatitis. However, we must also rule out other system, which is by asking the symptoms that commonly found with rash, which is when patient has joining swelling pain, abdominal pain or hematuria, so we must suspect patient might be HSP. So if there is any bleeding tendency, easy breathing, any that could be ITP, or any cough, coryza, measles, which is conjunctivitis also could be like suspect for Kawasaki. Kawasaki, and then if there is wheezing or stridor, especially patient with like preceded by when patient is allergic to something, patient may have a urticaria reaction, which is wheezing and stridor due to the airway edema, which is emergency for us to take this. So for the past medical history, we must ask the history of previous chickenpox before, any measles or immunization history, and also any drug history that patient is allergic for, because any current medication patient is taking because it could trigger the Stevens-Johnson syndrome. Okay, and then family history of skin disease or atopy. For the atopic dermatitis, and also for the social history, we must know the hygiene of patient. Also, is there any family members or at the daycare with a similar presentation to the patient. So for the physical examination, generally we need to know the age, general condition of the patient. Patient is look lethargic, like septic looking or not, and also vital signs in respiration or not, or hemodynamically stable. So as we can see, patient might be scratching in front of us. So just inspect generally because of the itchy rash. So for the skin examination, so before we start the skin examination, we must wear gloves and ensure adequate lighting and also exposure. So it is better for us to have a pentosh and also ruler for appropriate examination. So for the inspection, first we must expose the patient adequately. So in younger children, we can just expose them, remove the clothes completely. However, in older children, we must still cover the privacy part. Okay, so we need to know like the site, where is the site of rash, the number of rash is single or multiple, the extension of the rash is localized or widespread. So the distribution of rash, is it symmetrical or any like common site for each disease, or arrangement of the rash itself. Okay. And then next is palpation. So we need to know either the rash is flat or raised. So palpate the surface of the rash. We can also measure the lesions using a ruler. Okay. For the any hemorrhagic lesion, we can do a blanch test. It could be a blanching rash or non-blanching rash. So don't forget to check, even though it is a rash presentation. So don't forget to check for other systems patient complain of, which is their skin appendages, hair, nails, eyelashes, mucous membrane, scalp, or any eye involvement, the joints examination, also genitalia. Okay. So the investigation, it depends on our clinical suspicion on which type of the disease. So it may be divided just the same bedside investigation, lab investigation, imaging, and also a special investigation. So for the bedside investigation, you can do a throat swab, the patient complaint also for the gap infection. So for the lab investigation also, we might do like if throat swab, to support the evidence of streptococcal infection, we can do the RSOI titers. Okay. And then it depends on our clinical suspicion, what we suspect that patient. If the viral cause, usually there's not much investigation to be done since it is a self-limiting disease. So for the general treatment of the rashes, first we need to stabilize the patient first and give supporting and symptomatic treatment. So this is the most important part that we need to do to the patient, which is generally. So after that, we treat the underlying causes for the patient, which is if it is a viral causes, it is mostly self-limiting. So we can just do a supportive and also symptomatic treatment. So for the bacterial causes, that we need to eradicate the infection by giving the patient with antibiotics. Okay. And then specific treatment is different for specific disease. So in cases of immune complex causes such as Kawasaki, we might give IVIG to the patient. Okay, that's all for my presentation. So this is my reference. Any questions?
I have a question. It's two actually. It's more regarding to the terms used. Does the Foshman spot same with the palatal petechiae in Haziq? Hello, can you hear me? I have questions. Does the
Sorry, I cannot hear you.
You cannot hear me? Others can hear me?
So she's asking the, what is it called again? Hirschsprung spot is the same as palatal petechiae.
Dengar dari muncul Nano.
He's having audio problem. He can't hear.
Kena pergi bilik roommate apa housemate lah, bilik next to.
Yes, she has a roommate in our class.
Sorry, I couldn't hear what Nadia asking just now.
So she's asking you whether the susah nak sebut spot ni, apa nama spot ni?
Hirschsprung?
Hirschsprung spot is the same as palatal petechiae.
Basically, Hirschsprung spot, it is a red spot at the soft palate. So it's called as a Hirschsprung spot. I think, yeah, palatal petechiae, it could be at the hard palate or soft palate. So if it at the soft palate, we call it as a Hirschsprung spot.
One more. Does regular acne same with pustules?
Sorry, what?
Does regular acne, such as common acne, the same as pustules?
It depends. If the acne content of the pooling material, then it called as inflammatory acne. So it's like pustule is basically a general term that we call the rash as consists of the pooling material. So not every acne contain a pooling material. It can be just like a serous fluid.
Okay. Yep.
Any more questions?
Any more questions? No more question. Tak ada. No more question. That's fine then. So basically, I hate rash. Rash is just a rash. It's a skin lesion. The most important thing for pediatrics is if you see a rash, you want to know whether this is a blanching rash or non-blanching rash, because it's a life-saving test. So if you see a non-blanching rash, you need to think about meningococcal septicemia or meningitis, because it's a medical emergencies. The other kind of rash is not that emergency, but still obviously quite important to be diagnosed. For example, if you got a toxic epidermal necrolysis, or sometimes you can get septic bullous syndrome as well. So those are quite important as well, but it's a very rare occasion that you see bullous bullous skin conditions. And the bullous skin condition can be fatal if it's so big and it causes septicemia. And sometimes the bullous is due to autoimmune condition as well. So in that particular case, then you might need to do further investigation, including the skin biopsies or further autoimmune condition, autoimmune assessment, which is more difficult to diagnose. But normally we send them to the dermatology to diagnose them. Bullous conditions, I've not seen many of them. But most of the time I've seen them. Couple of cases I've seen them during the congenital period, which is neonatal periods. the other kind of skin condition that is quite severe, we call it ischemiosis, where you got the whole skin are very fragile. You know, even by rubbing the skin, it can slough the superficial skins. So those are ichthyosis type of skin conditions, but it's not really coming with a rash. It tends to come with kind of like, you know, a burst bullous, so it looks like the skin already peeling. So those are the worst kind of like skin condition in children. Okay, and the question. So back to apa nama ni, another question about Forscher's spots. Yes, Forscher's spot is the same as PTK spots on the pellets, but it tend to happen in soft pellets. Tadi kan Forscher tadi cakap pasal rubella kan? Can't remember, is it rubella? Rubella ke benda lain? Rubella kan?
Rubella.
So the thing is, it's only about if you got 10 patients with rubella, only 2 of them will have Forscher's spots, because it's about 20% of them, and then it tend to happen on the soft spots. The thing is, if you see a child with a skin rash, and then you see a child with the petechiae, then you need to think about rubella. If you see a patient like you know, scarlet fever, mana dia ada rash on the body, sandpapery rash, then they tend to have petechiae. The question now is what kind of rash they have. Okay, so scarlet fever tend to have sandpapery looking rash. Kalau macam rubella, the skin rash tend to be very small and then macam it's all over the body, tapi dia punya rash dia quite small and tend to be macule rather than quite like a big patch. So because macam scarlet fever tend to be quite a big rash, and then when you feel them, you feel sandpapery. The thing is quite difficult to differentiate these two rash, scarlet fever rash dengan rubella punya rash. Cuma rubella punya rash, it tend not to be macam mana because
it does not combine with each other.
Kalau macam scarlet tu, you can feel its race. Kalau macam rubella ni, it's just the rush that you don't feel apa, macam ada benda dekat apa, because if it race, you can feel it, something there. If it's not race, you don't feel it. So those are the difference between scarlet fever dengan rubella rash. But yeah, petechiae is a bit difficult to say whether it's a Forscher's spots or just a petechiae. For me, it just look the same anyway. It's just petechiae. And then normally, if I see a petechiae on the palate, I say this is petechiae. If somebody asks me, is it Forscher? I say I don't know. It's just petechiae. So okay. Right, another question. Okay, if there's no question, we can adjourn our session. So there's 29 of you, 28 of you. No further question, Aklan ada question tak, Aklan? Okay. Ada semua drive daripada all over the country. Ke ada orang naik flight daripada Sabah Sarawak? Oh, naik flight daripada KL. Okay, Solhi okay tak?
Tak ada.
Tak ada Okay, you okay
Okay,
still alive, still kicking Okay, good. Fine. So if there's no question, I think we can adjourn our session with Tasbih for us all. Okay, Assalamualaikum warahmatullahi wabarakatuh. Thank you very much.
Waalaikumsalam. Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.